Probably no greater misfortune can befall a family than the advent of a mentally defective child. Such a child presents many problems to the family and community. The family must give continuous care and protection to one whose body may gain adult size, but whose mind remains little better than that of an infant or a child. The more severely retarded require protection and care, which necessitate permanent placement in a state-supported institution. Those less severely retarded may remain in the care of their parents. Special school classes must be provided, geared to his slower mental development. Community supervision is often required to assist him to find employment. Because of ignorance and lack of self-control, the individual who is mentally retarded may easily be led into delinquency or into assuming responsibility he cannot meet. Community supervision becomes necessary to help him to conduct himself properly as an adult. Mental deficiency is, therefore, one of our major medical and it is estimated that more than 1.5 million individuals in the United States are mentally defective. Mental deficiency is frequently related to defective structure or function in the central nervous system, usually the brain. During fetal life and the first months after birth, the brain grows rapidly. The fetal brain changes markedly from month to month. It is during this period that many of the conditions which later result in mental deficiency originate. In general, the defects may be produced by environmental factors such as infections, trauma, or toxic agents, or it may stem from the inherent genetic constitution of the individual, producing malformations, metabolic disturbances, tumors, endocrine disorders, or other pathological conditions involving the nervous system. These conditions are most often present at birth, but may develop during childhood. The first sign of mental deficiency generally noted is the child's failure to develop the usual behavior patterns of children of the same age. Note this child's failure to grasp the object. 3 grades of deficiency are recognized. Moderately retarded individuals are referred to as morons. Those who are severely retarded are classed as imbeciles. And the very severely retarded are termed idiots. Intelligence tests are used to measure ability. Mary, a normal 8-year-old with a mental age of 12 years, is taking the mannequin test. By observing the time taken to complete the test, as well as accuracy of performance, it is possible to express her achievement as mental age, and from this derive a measure of her relative mental capacity known as the intelligence quotient. Our next subject, John, has a chronological age of 20 and a mental age of 7, which classifies him as a moron. Adults so classified achieve a developmental level comparable to normal 7 to 11-year-old children, the intelligence quotient ranging from 50 to 70. Ordinarily, they cannot completely meet the regular demands of family, school, or community life. However, those in the upper mental age levels of the moron group may be self-supporting under favorable conditions, including special supervision. John completes the mannequin test, but has the feet turned wrong. Now George will attempt it. George's chronological age is 20 years, but his mental age is only 4 years. This classifies him as an imbecile. Behavioral development in this group is comparable to normal 3 to 7-year-old children. The intelligence quotient ranges from 20 to 50. Imbeciles are unable to manage their daily affairs and require constant supervision. Here we see that George lacks the ability to comprehend the test problem. Next, we have Robert ready to try the mannequin test. His chronological age is also 20 years, but his mental age is only 2 years. This classifies him with the most severely retarded idiot group. In this group, behavioral development never exceeds that of a normal 3-year-old child, and the intelligence quotient is below 20. They are incapable of performing the simplest duties for themselves. Robert has no comprehension of the test problem, cannot concentrate, and does not even respond to the assistance given him. Another test commonly used is this Cites test, in which John, who is moderately retarded, is now working. John hesitates, but finally finds the correct places. The mental age rating on this test depends on the time consumed and the improvement on retrial. Next, we have George, who is severely retarded. He seems to have a fair understanding of the problem and makes an effort to solve it. He is, of course, very slow and does not readily see his mistakes. Yet eventually he completes the test. The difference in the responses of John and George illustrates the value of the test in measuring mental capacity. Next, Robert, who is very severely retarded, is offered the Cites test. Again, he displays a total lack of comprehension of the problem and a response poorer than that of the imbecile. Thus, the extent of deficiency in any given case is determined by the level of personal and social maturity exhibited, as well as by performance on certain standardized intelligence tests. In most cases of mental deficiency, there are few physical or pathological characteristics clearly denoting the defect. Several types of mental deficiency, however, do have well-defined physical and pathological syndromes. Best known among these types are hypertelorism, oxycephalus, microcephaly, hydrocephalus, cretinism, Mongolism. Frequently, but not necessarily associated with mental deficiency, are epilepsy and cerebral palsy. Hypertelorism is a congenital syndrome characterized by wide separation of the eyes and broadening or deformity of the nose. Mental and visual defect are present in all but the very mild cases. More than one case occurring in a family may indicate a hereditary factor. Hypertelorism is rather uncommon. There is no treatment for this condition. Oxycephaly is one variety of a skull malformation known as craniosynostosis. This is due to premature closure of the cranial sutures. The forehead is high with a ridge at the site of the midline suture. Because of the distortion of the greater wing of the sphenoid bone, the nose is hooked and the lower jaw large. Many of these patients also develop bulging eyes and partial or total blindness. They are usually mentally deficient. Operative procedures to reopen the sutures are done in some cases with infants in the hope of improving the outlook for both visual and mental development. Microcephaly is so named because those afflicted with it have exceptionally small heads. The growth of the skull is related to the growth of the brain within it. In microcephaly, the brain fails to grow to normal size, and thus the skull remains small. The head of this 18-year-old microcephalic measures 14 inches in circumference, whereas 22 inches is normal. The head is cone-shaped, with a narrow, receding forehead, flattened occiput, prominent nose, and receding chin. This woman has a mental age of less than 3 years. Her sister has about the same mentality. They understand a few simple commands, but cannot talk. Note how the normal head on the left and the microcephalic head on the right differ in size and shape. Compare the brain of a normal adult with that of a 32-year-old microcephalic. The microcephalic cerebellum is fairly well developed, but the cerebral hemispheres are underdeveloped. This 28-year-old woman is another microcephalic. She is unable to talk, except for a monkey-like chatter. Microcephalics are helpless people. They learn only rudiments of personal hygiene and how to perform a few simple tasks. Compare the behavior of the moderately retarded person on the left with the microcephalic. The cerebellum of the microcephalic brain on the right is larger than that of the orangutan's brain on the left. However, the latter shows more mature markings in the cerebral hemispheres. This 37-year-old microcephalic has an IQ of 23. Born of mentally normal parents, she has a brother who is also microcephalic. She illustrates well the characteristics and behavior of these cases. In true microcephaly, the brain develops little after the 5th embryonic month. Compare this adult microcephalic brain with a photograph of the normal embryonic brain at the 5th month of development and at the 7th month. These subjects are identical twin microcephalics with very small heads. Compare this one with a normal person. The twins are 30 years old. Because of the rarity of occurrence of microcephalic twins and their classical appearance, these women have often been used to illustrate the condition. Their mental age is less than 3 years. In microcephaly, there is an irregular development of the cerebral cortex, with a lack of brain cells most noticeable in the parietal and occipital lobe. In general, microcephalics are timid, restless, imitative, make quick, monkey-like movements, and are relatively insensible to pain. There is no medical treatment for these cases. Hydrocephalus is a condition characterized by excessive accumulation of cerebrospinal fluid within the brain ventricles, causing enlargement of the skull. This baby's large head is typical. The skin condition is not related to the hydrocephalus. Though hydrocephalus often develops during fetal life, it is seldom apparent until some weeks after birth. Then, the rapid increase in the size of the infant's head, the bulging fontanelles, and the widespread sutures make the diagnosis relatively simple. In the postnatal or acquired type, if the sutures and fontanelles are already closed, symptoms of intracranial pressure develop, but the size of the head remains normal. Usually, the intellectual development of these patients is arrested in early infancy, and they become severely retarded. This cast shows the ventricular system of the brain in its proper position in the skull. Here, the cerebrospinal fluid originates and circulates. This system consists of these two large lateral ventricles or cavities. In the floor of these are located the cells which secrete most of the cerebrospinal fluid. From here, the fluid passes into this small cavity known as the third ventricle. Then it passes through a canal called the aqueduct of Sylvius into the fourth ventricle and into the subarachnoid spaces surrounding the brain and spinal cord. Part of the fluid flows down and covers the spinal cord, while the remainder flows up over the surface of the cerebral hemispheres where it is absorbed. The facial features of a hydrocephalic person appear small. The forehead is high and overhanging. The veins are distended, and the eyelids are elevated by tension of the scalp to expose the white of the eyes. Hydrocephalus is usually due to an obstruction in the normal circulation of the spinal fluid. However, it may also result from destruction of absorption areas or from oversecretion. Much of the brain structure and spinal fluid pathways can be examined by means of the pneumoencephalogram. This involves replacing some spinal fluid with air or gas and X-raying the head. The X-ray plates register the contrast between the air and brain tissue. Observe the dilation of the ventricles and the thinned-out bones of the skull. The fluid is unable to pass into the absorption areas because the pathways are blocked. Hydrocephalics seldom live beyond childhood. If they do, as in this case, the accumulated fluid in the lateral ventricle causes pressure on the brain structures and thinning of the cortex. The result is widespread paralysis, deformity, and optic atrophy. This 4-year-old child, helpless and severely retarded, again illustrates congenital hydrocephalus, the cause of which is obscure. In this 10-year-old girl, hydrocephalus developed following an attack of meningitis when she was 3 years old. Hydrocephalus may follow such diseases as encephalitis and syphilis. It may also occur with spina bifida, meningoceles, and tumors of the brain. This final case, a severely retarded 8-year-old, once more presents a typical picture of severe congenital hydrocephalus with marked optic nerve degeneration, paralysis, and enlargement of the skull. Neurosurgical operations to correct hydrocephalus offer some hope of success if performed early in life when the destruction of brain tissue has been minimal. Another readily discernible type of mental deficiency is cretinism, which is characterized by dwarfism and inferior mental development due to an inadequate supply of the thyroid hormone thyroxine. In this 30-year-old cretin, the function of the thyroid gland was impaired by accident or disease. This woman, 35 years old, also has cretinism. The mental capacity of cretins ranges from mild to very severe retardation, depending on the degree of thyroid impairment. These women are sisters, 28 and 37 years of age. They illustrate the familial tendency to cretinism. In cretinism, the parents are usually normal. The child appears normal at birth because the mother's blood has supplied the fetus the necessary amount of thyroxine for normal growth. In this sister, there is a congenital absence of the thyroid gland, while in this one, the rounded cystic mass appearing on the throat demonstrates an apparent congenital disorder of the thyroid gland. Signs of cretinism usually appear before the child is 3 months old. The child becomes dull and apathetic. This 15-year-old boy, who looks like a 7-year-old, has a mental age of less than 3 years. Observe the large abdomen and the retarded genital development. A consistent abnormality in cretinism is the delayed appearance of the centers of ossification. Compare this X-ray of the wrist of a 10-year-old cretin with the wrist of a normal 10-year-old. After 1 year of treatment, the centers of ossification appear. More appeared after 2 years of thyroid treatment. This 39-year-old cretin, who is severely retarded, is unable to talk or walk unaided. The skeleton is dwarfed, the trunk and limbs short and heavy, the chest large. This 47-year-old cretin has a mental age of less than 2 years. The coarse features, low forehead, open, drooling mouth, and large protruding tongue are associated with the retardation. Prompt, vigorous treatment will enable many cretins to develop more adequately, although they never attain completely normal development. Another form of mental deficiency is Mongolism, so called because those afflicted bear a superficial resemblance to the Mongolian race. This 4-year-old Mongol has a mental age of 2 years. He was born to normal. The other children in the family were normal. Mongol's mental deficiency is due to faulty embryonic development. More Mongolian babies are born to mothers late in their reproductive life than would occur by chance. Endocrine dysfunction may at some future time be proved responsible. This 9-year-old Mongolian girl has a mental age of 3 years. Her features are similar to other Mongols. The tongue is unusually large and long. It often protrudes. There are deep transverse fissures on its surface. The hands are broad and the fingers stubby. The muscles are flaccid and the joints extremely flexible. The general appearance of this 16-year-old Mongol is also characteristic of the group. Her eyes are slanting, her nose saddle-shaped, her teeth poor. In Mongols, the eruption of the teeth is usually delayed and the dentition faulty. This 24-year-old man has a mental age of 4 years. He has the Mongol's typical physical characteristics: a brachycephalic head, large tongue, short, broad hands. These people have been termed Mongolian idiots incorrectly, since most of them are imbeciles. Identical twins such as these occur very rarely. Mongols seldom reach a mental age above 5 years. They respond only moderately well to training, but are usually placid and affectionate in disposition. This 52-year-old Mongolian woman illustrates the fact that, despite generally low vitality and susceptibility to respiratory diseases, they can and do live to an advanced age. The eyes of Mongols have oblique, palpable fissures with an epicanthal fold of skin at the median angle. No treatment has been found to be of great value, and institutional care is frequently required. Epilepsy is a symptom of nervous system dysfunction. It is frequently accompanied by, but is not the cause of, mental deficiency. Epilepsy is characterized by recurrent attacks of loss of consciousness, usually accompanied by convulsions. This girl illustrates petit mal epilepsy. Her sister, too, has petit mal epilepsy. Petit mal seizures are usually frequent, but rarely dramatic or injurious to the patient. They may occur only occasionally, or as often as several hundred times a day. As time goes on, however, petit mal seizures tend to become more severe and frequent until they resemble grand mal attacks. Petit mal attacks are characterized by a momentary drooping of the head. It seldom lasts longer than 15 seconds, and the patient rarely falls. Here, the smaller girl is having a seizure. Probably 1 million people in the United States are afflicted with epilepsy, of whom only a small proportion are mentally defective. While epilepsy was one of the first disorders to be described in medical literature, only recently has real progress been made in understanding the condition. Again, the girl on the right has an attack. It is more pronounced this time. Now she has another attack, during which she almost falls. This subject has several hundred petit mal seizures every day, occurring almost continuously. For the purpose of this demonstration, she is asked to breathe deeply. This produces an alkalosis in the blood, which tends to increase the number of convulsive seizures. Epilepsy is classified as either idiopathic or organic. In the idiopathic type, the cause is unknown. In the organic type, some definite abnormality is present, such as a congenital defect or an injury to the brain. Most cases that are properly diagnosed as epilepsy are of the idiopathic type. Predisposition to this disorder may be inherited. Attacks of the petit mal type follow one general pattern. There is a sudden lapse of consciousness, during which there is a vacant stare and fluttering of the eyelids. If the patient is doing anything when the attack occurs, there is a momentary cessation, then a continuation of the action, often without the person being aware of the interruption. There is evidence to suggest that the normal physiological interchange of fluid and electrolytes in the brain cells may become disturbed, and that this is responsible for the interruption of the normal brain rhythm, which is now thought to cause epileptic seizures. This man has the more severe form of seizure, known as grand mal epilepsy, which he has had for many years. He is also mentally retarded. His nose is deformed from many falls. He has kept a record of his many seizures and is now showing a page in his daily record book. It indicates 21 seizures one day and 18 another. The patient shows us his monthly and yearly records of attacks. He is very proud of the fact that he holds first place in this institution for the number of convulsions. Grand mal seizures are more severe and generalized than petit mal. In grand mal epilepsy, there is usually a period just preceding the attack when the patient experiences a disturbing sensation known as an aura. During this period, a definite change from the normal brain rhythm occurs. When the attack begins, the patient usually utters a sharp cry, and if standing or sitting, suddenly falls. This man's attacks are not as violent as is usual because he is under treatment. Many types of treatment have been suggested in the past, but at present the most satisfactory treatment is provided by anticonvulsant drugs. In the organic type of epilepsy, operations to remove pressure, adhesions, tumors, or cysts from the brain have been beneficial in some instances. In a typical grand mal attack, marked pallor is followed by deep cyanosis. The body is rigid at first, then clonic spasms of the muscles cause the limbs to jerk in a typical convulsive movement. These quickly involve the head, trunk, and limbs. The eyes roll upward or deviate to one side. The pupils dilate, and the facial expression becomes distorted. After a remission of a minute or less, the convulsions are usually repeated. The entire seizure may last for several minutes. Then the patient will usually sleep. Mental deficiency is quite common among individuals with cerebral palsy, which is characterized by motor system dysfunction due to central nervous system disorder. In this first case, observe the paralysis and atrophy of the left arm and leg, resulting from defective function of the right side of the brain. In this second case, note the paralysis of the right arm and leg, with resultant deformity of the right foot. Both women are severely retarded. The brain impairment may be congenital, caused either by defective germplasm or by poor blood supply, hemorrhage, or infection. It may also occur during birth as a result of hemorrhage, direct trauma, or prolonged asphyxia. This case demonstrates paraplegia, or paralysis of the legs only, with marked mental impairment. This is another case of paraplegia. This case demonstrates diplegia, a more extensive brain injury resulting in severe mental impairment, paralysis of all four limbs, and, to some extent, the muscles of the body. There is very little twisting or intention tremor, the condition being one of tonic spasm, which the patient has little ability to overcome. In severe cases, such as the present subject, contractions of the involved muscles result in permanent deformity of the limbs and, to some extent, of the entire body. This pneumoencephalogram was done on an individual with cerebral palsy. Pathological changes, such as this large cavity, can usually be recognized in the brain structure. They occur principally in the cortex, pyramidal tract, basal ganglion, and occasionally in the cerebellum. Often, in severe cases, much of the upper brain structures are absent or rudimentary. In some cases, however, little abnormality can be demonstrated. This pneumoencephalogram was done on a very severely retarded person with congenital spastic paralysis. The right cerebral hemisphere has atrophied. The symptoms are largely manifestations of the impairment of brain structures. They vary according to the degree and site of the brain injury. Here is a pneumoencephalogram of another person with cerebral palsy, complicated by convulsive seizures. Note large dark cavity on the side. It is probably of congenital origin. This one, too, illustrates congenital malformation of the brain. This is a pneumoencephalogram of a 1-year-old child who is severely retarded and has general spastic paralysis. Observe the airspace over the cerebrum, with atrophied cerebral hemisphere showing just above the fluid line. This view demonstrates the extent of brain atrophy. In cerebral palsy, more than one part of the brain is often involved. In the cases demonstrated so far, the defects were in the cortex and pyramidal tracts. The tremor and incoordination accompanying spasticity in this case indicate not only injury to the brain surface and motor tracts, but also to the groups of cells at the base of the brain, the basal ganglion. In such instances, the injury predominantly involves the extrapyramidal tract structures. This boy, whose mental development is but slightly affected, illustrates the almost pure tremor type. This woman excellently demonstrates marked tremor with incoordinated and uncontrolled movements of the spastic choreiform type. The prognosis in all types of cerebral palsy depends on the location and extent of brain defect. When the mental development is markedly impaired, there is little hope of success in overcoming the effects of the motor disability. If, however, the patient is normal or nearly normal mentally, and the physical disability neither too severe nor too widespread, some help can be given. The purposeless, violent movement of the legs, arms, and trunk of this patient again well illustrates the predominantly choreiform type of cerebral palsy. Observe the contraction of the neck muscles and the facial grimaces, but the absence of tremor or athetosis. This final case of cerebral palsy is of the predominantly atrophic type of extrapyramidal tract injury. These attitudes are usually described as aimless, uncoordinated movements. However, close study indicates that these movements are constantly the same in any given situation, and that they are of an orderly sequence. The very intensity of purpose exerted by this woman as she attempts to grasp something overstimulates the muscular contraction, which defeats the purpose of the intended movement. When the patient's mentality will permit, some progress may be made by teaching the choreiform and athetotic types extreme relaxation of movement. In the motor type, where spasticity predominates, properly directed physical therapy may lead to significant improvement in motor function. These are a few well-known types of mental defectives, including those with epilepsy or cerebral palsy. While comprising only a small part of the total group, They have been demonstrated because of the clear-cut pathology involved. The majority of those classed as mentally deficient are noteworthy only for their limited intelligence and their social inadequacy, the causes of which may be quite complex. To assure them the protection they often need and to make possible the maximum development of their limited skills, society must provide special programs of education, training, and, when necessary, lifelong supervision and care.